Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important type of vasculitis, that is Kawasaki disease. So, Kawasaki disease, let me tell you, it is a medium vessel vasculitis. Right, it is a medium vessel vasculitis. Now, let me just show you how the questions can be asked on this topic of Kawasaki disease. So, the question is like this. Kawasaki is associated with all of the following features except erythema, posterior cervical lymphadenopathy, thrombocytopenia, conjunctivitis. So, this is how the questions can be asked on Kawasaki. Okay. So, first what I will do, I will just discuss the entire topic of Kawasaki and then we will solve these type of multiple choice questions on the topic of Kawasaki disease. So, if you take Kawasaki disease, it is a medium vessel vasculitis, that is what I was telling you, and it is a multi-system disease. Right, it is a multi-system disease. And another name of this Kawasaki disease, it is also known as mucocutaneous lymph node syndrome. Right, also known as mucocutaneous lymph node syndrome. Okay, so this is another name for the Kawasaki disease. Now, you should know what is the age group at which this particular Kawasaki disease is being present. So, Kawasaki is the type of vasculitis which is seen commonly in children. And at the same time, you should also know what is the age group at which you will see this Kawasaki. It occurs mainly in children between the ages of 3 months and 5 years. Right, between the ages of 3 months and 5 years. So, that is the age group at which you will have the development of this Kawasaki disease. And occasionally, right, and rarely it can be seen in adults as well. But most commonly it is seen in children. So, that is about the age at which you have the Kawasaki. And if you see the epidemiology of this Kawasaki most often it is seen in Asians or native Pacific Islanders. And if you see the incidence of Kawasaki in Japan, right, it is almost twice, right, it is almost twice then compared to that of the United States. So, this particular Kawasaki is very common in Asian countries and that too within the Japan. And the incidence of this particular Kawasaki, it occurs among siblings at twice the incidence of cases. So, among the siblings, right, among the siblings, this occurs almost twice the incidence of twice then compared to that of the siblings who doesn't have this Kawasaki, right, and it is also seen at a higher rates among parents of the cases with Kawasaki. So, basically either siblings affected with Kawasaki, there is twice chance, almost like double the chance in the sibling, and if the parents has Kawasaki, the progeny, that is children, also has the highest incidence of the development of this Kawasaki disease. Right, now after having discussed about the epidemiology, let me discuss what are the factors, what are the risk factors which will predispose to the development of the Kawasaki disease. Let me tell you, the epidemiological studies have shown that there is increased risk with advanced maternal age. Right, there is increased risk with right, there is increased risk with advanced maternal age. And second important, mother, right, if the mother having Group B, streptococcal colonization. Then also right, then also there is increased incidence of development of this Kawasaki disease. And not only that, early infancy hospitalization for bacterial illness, right, early infancy with bacterial illness, right, hospitalized for bacterial illness. Okay, so these are the risk factors which will predispose the individual for the development of the Kawasaki disease. Now at the same time, you should know what is the pathogenesis for the development of the Kawasaki disease. Kawasaki as such, it's an acute self-limiting condition. Right, it's an acute self-limiting condition wherein it is characterized by infiltration of the vessel wall with mononuclear cells. Right, there is infiltration of vessel wall right, infiltration of vessel wall with mononuclear cells, and later the infiltration is by IgA secreting plasma cells. Right, later it is by infiltration of IgA secreting plasma cells, and this can result in this mononuclear cells and as well as the IgA secreting plasma cells. Both of these, they can cause the destruction of the tunica media. Right, both of these, they can cause the destruction of the tunica media. So once there is destruction of the tunica media, that will result in the aneurysm formation. Right, that will result in the aneurysm formation. So this is the basic pathogenesis. So it's an acute self-limiting mucocutaneous vasculitis which is characterized by infiltration of vessel wall with mononuclear cells and later by IgA secreting plasma cells. And these mononuclear cells and IgA secreting plasma cells, both of them, they cause the destruction of the tunica media and then there will be aneurysm formation. So this is the pathogenesis of the Kawasaki disease. Now, we have a clinical entity called as MISC. So what does this stands for? Multi-system inflammatory syndrome in children. Now, what is this multi-system inflammatory syndrome in children is that? So, in Italy, we have a place called Bergamo. Right, so this is a place in Italy and this was considered to be an epicenter of 2020 SARS coronavirus pandemic. Right, so this was considered to be an epicenter for SARS coronavirus pandemic. So, in this place called Bergamo, there was almost a small cluster of 10 children with Kawasaki-like disease. Right, there was almost 10 children with a Kawasaki-like disease. And they were found to have this multi-system inflammatory syndrome in children. So what they found was this MISC, it is due to immune response. Right, it is due to immune response to SARS coronavirus 2. Right, now what exactly happens in this? Now, in this, once the child gets infected with SARS coronavirus 2, this MISC has been observed. Now, what is the CDC definition of the MISC, right? What happens in this actually? Now, let me tell you what exactly is the CDC case definition of MISC. First and foremost, the patient's age should be younger than 21 years, right? The age of the individual should be less than 21 years, and the individual should have had high grade fever, right? High grade fever, and the temperature, it is more than 38 degrees centigrade, right? Temperature, it is more than 38 degrees centigrade for at least 24 hours, right? For at least 24 hours. Second point is, there should be laboratory evidence of inflammation, right? There should be laboratory evidence of inflammation, like ESR should be raised and CRP also should be raised. So this is laboratory evidence of inflammation. And third important thing is, there is evidence of clinically severe illness that requires hospitalization. Right? So, evidence of clinically severe illness that requires hospitalization. And why is this particular hospitalization? That is because of multi-system involvement. Right? That is because of the multi-system involvement. Right? So, there can be involvement of cardiac, involvement of renal, involvement of respiratory, involvement of hematological, involvement of gastrointestinal, dermatological or neurological systems. So, that is the third criteria. And the fourth important criteria is, no alternative diagnosis should be possible. Right? No alternative diagnosis should be possible. So, this is the CDC case definition of MISE. Right? Now, after having discussed about so basically what is this MISC now? It is the one which occurs in children of age group less than 21 years, secondary to your SARS coronavirus 2 infection, right? Wherein the individual will have the features similar to that of Kawasaki. Now, you should know in Kawasaki what are the vessels that are being affected. So, we have discussed that it is a medium vessels, right? It is your medium sized vessels that are being affected, right? And along with the medium sized vessels, there can be involvement of small or large vessels, but this involvement of small or large vessels, it occurs occasionally, right? It occurs occasionally. So that is about the vessels which are affected in Kawasaki disease. Now, you should know the two main characteristic features of the Kawasaki disease. That is, you should know what is the most common vessel affected, and this vasculitis is associated with other important disorder. That is what you have to know. So, if you take the vessels which are commonly affected in these patients with the Kawasaki, it is the coronary artery. Right, it is the coronary artery. So, because of the involvement of the coronary artery, this gives rise to important cardiac manifestations. And this particular vasculitis, it is associated with mucocutaneous lymph node syndrome. Right, it is associated with mucocutaneous lymph node syndrome. Okay, now if you observe the platelets in these patients with the Kawasaki, right? In the multiple choice question which I have shown you, one of the option was thrombocytopenia. Thrombocytopenia will not be there in Kawasaki. What is that you will have is thrombocytosis, right? So the two important features in patients with Kawasaki is that Kawasaki is associated with the involvement of coronary artery most commonly, and it is associated with the mucocutaneous lymph node syndrome. Now, if you see the type of inflammation in patients with the Kawasaki disease, it is non-granulomatous inflammation. Right, it is the non-granulomatous inflammation that you will have in patients with the Kawasaki disease. And pathogenesis we have discussed, it's an immune-mediated injury to the vessel endothelium with infiltration of the mononuclear cells. Now, followed by that, you should know the clinical features in Kawasaki, in which you need to know what is the most common symptom in patients with Kawasaki disease. Most common symptom in patients with Kawasaki disease is the fever. Right, so there will be a prior history of fever for nearly around 4 to 5 days. So fever is the most important constitutional symptom in patients with the Kawasaki disease. Then followed by that, I said you another name of Kawasaki disease is mucocutaneous lymph node syndrome. Now let me discuss what is that particular lymph node which is involved and what will happen to the size of the lymph node. So the individual will develop what is called cervical lymphadenopathy. Right, the individual will develop cervical lymphadenopathy. And this lymph node or lymphadenopathy, cervical lymphadenopathy, whatever is there, it is usually unilateral and it is a non-suppurative lymphadenopathy. Right, it is a non-suppurative lymphadenopathy. And what will happen to the size of the lymph nodes? The size of the lymph nodes is usually more than 1.5 centimeters. Right, the size of the lymph node is usually more than 1.5 centimeters. So that is about the lymph node involvement. Now, regarding the vessel involvement or the vasculitis, as already I have mentioned, it is the coronary artery, right? It is the coronary artery which is most commonly affected in patients with the Kawasaki. And because of the part of vasculitis, what will happen to the coronary artery? There will be development of aneurysm within the coronary artery, right? It is associated with the coronary artery aneurysm. And this coronary artery aneurysm, it is almost seen in 25% of patients, right? And this Kawasaki, it is a self-limiting disease, but sometimes in almost 5 to 10% of individuals, they are associated with very severe fatal complications. Then in these patients with Kawasaki, it is mucocutaneous, right? Even there will be involvement of the skin and there will be presence of rash over the skin. And the description of the rash is, it is polymorphous, exanthematous rash. Right, this polymorphous exanthematous rash, it is distributed over the extremities. Right, it is distributed over the extremities, that is in the upper limbs and as well as in the lower limbs. Okay, that is where you have the presence of this particular rash. Next, then followed by that, you need to know in patients with Kawasaki, there is also involvement of the conjunctiva. So what will be the conjunctival changes in patients with the Kawasaki disease? So there will be bilateral bulbar conjunctival injection. Right, so there will be development of bilateral bulbar conjunctival injection or congestion, right, but there is no exudates, right, there is no exudates within the conjunctiva. So we call this as non-purulent conjunctivitis. right? We call this as non-purulent conjunctivitis. So that is about the involvement of conjunctiva in Kawasaki disease. Then followed by that, you need to know what will happen to the lips and oral cavity, and as well as what will happen to the tongue. See, the tongue that you will observe in patients with Kawasaki is, we call this as a strawberry tongue. Right? And if you observe the lips and oral cavity, there will be erythema. Right? There will be lip cracking. Right? There will be erythema, there will be lip cracking, and there will be also congestion of oral and pharyngeal mucosa. Right? Congestion of oral and pharyngeal mucosa. So that is what you will observe the lips and oral cavity in patients with the Kawasaki disease. Now, after having discussed about the conjunctiva and tongue, what are the other manifestations that you will have in these patients with the Kawasaki disease? So one is your lymph node, right? It is cervical lymphadenopathy, that too unilateral, and it is a non-suppurative lymphadenopathy, and size of the lymph node is more than 1.5 centimeter. The other thing is mucocutaneous manifestations. You have that erythematous rash present over the palms and soles, and there will be also edema of the feet, right? If you see the extremities, there will be edema of the feet. And lips and oral cavity, there will be lip cracking, erythema, congestion of the oral and pharyngeal mucosa, and there will be development of the strawberry tongue. And conjunctiva, if you see, there will be presence of bilateral bulbar conjunctival congestion, and there is no exudates, and it will be non-purulent conjunctivitis. So that is what you will see in patients with the Kawasaki disease. Now, what are the other manifestations that you will observe in patients with the Kawasaki disease? So, there will be involvement of the pericardium and as well as myocardium, and involvement of pericardium will be in the form of pericarditis, and involvement of myocardium, right, that is in the form of the myocarditis, and there can be also development of myocardial infarction, right? There can be also development of the myocardial infarction. So this is about the manifestations that you will see in patients with the Kawasaki disease. Then followed by that, you need to know what is the criteria for Kawasaki disease. See, the criteria for Kawasaki is that we have totally 5 important criteria along with fever. So fever should definitely be there, and this particular fever should be present for more than 5 days. Right, should be present for more than 5 days. And along with fever, please remember the criteria. For that, I will just give you a mnemonic, that is CREAM. The word C stands for conjunctivitis. And what type of conjunctivitis is this? It is a non-exudative or non-purulent conjunctivitis. And the word R is the rash, right? And what type of rash is that the individual will have? It is a polymorphous non-vesicular rash. E stands for edema, and this edema is present over the extremities, right? That is over the hands or feet. Right, over the hands or feet. And the word A is adenopathy, right? And what adenopathy is that? It is the cervical, right? It is cervical lymphadenopathy, and that too it is unilateral, right? That too it is unilateral. And the word M stands for mucosal involvement. Right, the word M stands for mucosal involvement, right, wherein there will be development of erythema, that is redness, right, wherein there will be development of erythema or fissuring or crusting. So that is about this particular criteria, that is CREAM. And out of these 5 criteria, right, out of these 5 criteria, 4 should be present, right? 4 out of the following, 4 out of 5 of the following is the one which is giving you the diagnosis of the Kawasaki disease. Now this is an image of an image of a child with a Kawasaki, right? So this is a imaginary image wherein you can make out that there is presence of fever for nearly around 5 days, right? And bilateral non-exudative conjunctivitis, involvement of the lips and oral cavity, the strawberry tongue, coronary arteries, there is coronary artery aneurysm, right? Unilateral cervical lymphadenopathy, right? Rash which is present all over the body, right? It is the polymorphous rash, and you can observe that there is presence of edema, that is both in the upper limbs and as well as in the lower limbs. Okay, so this is a summary of the entire Kawasaki. So you have the vasculitis component and you have the mucocutaneous lymph node component. Vasculitis component, coronary artery involvement. Mucocutaneous lymph node involvement of the eye, involvement of the skin, and there will be involvement of your cervical lymph nodes. Now this particular Kawasaki, right, you have totally 3 phases. Right, it is generally divided into 3 clinical phases. Now, what will be the features of these 3 clinical phases? So, if you observe the features of these 3 clinical phases, we have actually acute febrile phase, subacute phase, and then we have convalescent phase. Acute febrile phase is that it is characterized by high spiking fever. Right, the individual has high spiking fever, and this high spiking fever, it is unresponsive to antibiotics. Right, it is unresponsive to antibiotics, and this particular fever, it lasts for around 1 to 2 weeks. Right, it will be present around for 1 to 2 weeks. Then you take subacute phase. This phase, it is associated with desquamation. Right, it is associated with desquamation, then thrombocytosis, right, thrombocytosis, and development of coronary artery aneurysm. Right, development of coronary artery aneurysm. And these individuals with development of coronary artery aneurysm, they have the highest risk of sudden death. Right, they have the highest risk of sudden death. So that will be the subacute phase. Then followed by that, the convalescent phase. So if you see this convalescent phase, this phase begins when all clinical signs of illness have disappeared. So all clinical signs right, all the clinical signs right, this phase begins when all the clinical signs have disappeared and continues until the ESR returns back to normal. Right, continues until the ESR returns back to normal. Right, and when will this convalescent phase will be? It is approximately present 6 to 8 weeks after the illness. Right, it is approximately present 6 to 8 weeks after the illness. So this is about your convalescent phase. Right, so these are the 3 clinical phases of Kawasaki. One is acute febrile phase, subacute phase, and then convalescent phase. So acute febrile phase, where the individual will have a high spiking fever, remittent and unresponsive to antibiotics. The fever will be present for nearly around 1 to 2 weeks. Subacute phase, this is associated with desquamation, thrombocytosis, and coronary artery aneurysms, right? And there is high risk of sudden cardiac death. The convalescent phase, this phase begins when all the clinical signs of illness have disappeared and continue until the ESR returns to normal, and approximately it is present like 6 to 8 weeks after the illness. So these are the 3 important clinical phases of Kawasaki. So Kawasaki is associated with all of the following features except erythema, posterior cervical lymphadenopathy, thrombocytopenia, conjunctivitis. So what is the answer here? So they will not have thrombocytopenia. What they have is thrombocytosis. That is what you will observe in patients with the Kawasaki disease. Then if you see the investigations in patients with the Kawasaki disease. So most of the times Kawasaki, it is diagnosed clinically, right, based on the age group and based on the clinical manifestations. Most of the times it is being diagnosed. So laboratory features will just give you an add-on to your diagnosis of the Kawasaki disease. Now if you take the investigations, WBC count, right, there will be leukocytosis, because it being an inflammatory pathology, so the WBCs, they are increased, right, WBCs, they are increased. Then which type of WBCs are predominantly elevated, right? WBC is elevated with predominance of neutrophils, right, with predominance of neutrophils. And platelets, if you see, there will be thrombocytosis, and this particular thrombocytosis is observed after 1 week, right, it is observed after 1 week. And if you see the acute phase reactants, the acute phase reactants like ESR and as well as CRP, both of them, they are elevated, right, ESR and CRP, both of them, they are elevated. And these individuals, they have anemia of chronic disease, right, that will be due to inflammation. The individual will develop what is called normocytic anemia, right, the individual will develop what is called normocytic anemia. Then if you observe the CSF, right, the CSF will show you the presence of pleocytosis, right, where there will be increase in the WBCs even within the cerebrospinal fluid as well. Then even if you observe the synovial fluid, right, even within the synovial fluid there is leukocytosis and they will have hypoalbuminemia. So this will be the investigations in patients with the Kawasaki. And another very important investigation is the two-dimensional echocardiography. So two-dimensional echocardiography, let me tell you, this will give you the picture of the coronary artery. So you will be able to make out if there is any presence of coronary artery abnormality. Right, you will be able to make out if there is any presence of the coronary artery abnormality. So therefore, the two-dimensional echocardiography monitoring is done, right, to assess the coronary artery. And you will also be able to make out if there is any presence of the coronary artery aneurysm, right. Next, the other important investigation is NT-proBNP, right, NT-proBNP, that is pro-brain natriuretic peptide. NT stands for N-terminal. So NT stands for N-terminal moiety of brain natriuretic peptide. Okay, so that is what you mean by this word NT-proBNP. So if NT-proBNP is raised, that is indicative of myocardial involvement. Right, that is indicative of the myocardial involvement, right, and this may be elevated in some patients with the Kawasaki disease. So wherever there is myocardial involvement causing congestive heart failure, your NT-proBNP will be elevated. Then the another important investigation is non-invasive diagnosis of the coronary complications. So this non-invasive diagnosis of coronary complications can be made by CT coronary angiography. right? CT coronary angiography, right? So CT coronary angiography, this is the most sensitive test, right? And another or other non-invasive methods of diagnosing of coronary complication is magnetic resonance angiography. Right, magnetic resonance angiography or transthoracic echocardiography. Right, echocardiography, just now I was discussing. So these are the non-invasive methods for diagnosing the coronary complications. What are those? Like coronary artery aneurysms, right? And this transthoracic echocardiography, it can be applied as an early screening tool, right? It can be applied as an early screening tool. So these are the methods by which you will diagnose the Kawasaki disease, but most of the times the Kawasaki is diagnosed clinically rather than the investigations, and investigations just they will give you an add-on. Next, the question is, which one of the following is the treatment of choice for Kawasaki? Let me discuss the treatment. So until now, like we have discussed, what exactly are the important clinical manifestations and how do you diagnose Kawasaki? Now let me take up the discussion of the treatment of Kawasaki. So which of the following is the treatment of choice for Kawasaki? Cyclosporin, dapsone, intravenous immunoglobulin, and then methotrexate. So you have to know that in patients with Kawasaki, the drug of choice, it is intravenous immunoglobulin. Right, it is intravenous immunoglobulin. So a single dose of the intravenous immunoglobulin, this has to be given, right, single dose, right, this has to be given in first 10 days of illness. Right, in first 10 days of illness, you have to give a single dose of intravenous immunoglobulin. And patients in whom the diagnosis was made later than 10th day, right, for example, if the diagnosis is made beyond 10th day, right, if the diagnosis is made later than 10th day, still benefit from IVIG treatment can be done, right? So you can give intravenous immunoglobulin, right? You can give intravenous immunoglobulin if the ESR and as well as CRP, if they are elevated, right? If the ESR and CRP are elevated even beyond 10th day, then you can give this intravenous immunoglobulin. And even beyond 10th day, you can give intravenous immunoglobulin if there is presence of the persistent fever. Right, if there is presence of the persistent fever, or if the individual have the coronary artery aneurysm even beyond the 10th day, you have to give this particular intravenous immunoglobulin, right? Now the point is, you need to know that intravenous immunoglobulin treatment is not given for suppose if intravenous immunoglobulin is not given, actually the drug of choice is IVIG. For suppose if intravenous immunoglobulin, if it is not given, then there is chance of development of coronary artery aneurysm in 20% of children, right? There is chance of development of coronary artery aneurysm in 20% of children. And when we are giving IVIG within 10 days, right? If we are giving IVIG within 10 days, then the chance of development of coronary artery aneurysm will reduce. But still, you can have the development of coronary artery aneurysm even in 5% of individuals in spite of giving IVIG within 10 days of illness, right? Next. Now, let me discuss some of the complications associated with the intravenous immunoglobulin supplementation. So the complications, they include rare cases of aseptic meningitis. Okay, rare cases of aseptic meningitis are reported with intravenous immunoglobulin. Right. Now, apart from the development of aseptic meningitis, the other complications include Coombs positive hemolytic anemia, right? Coombs positive hemolytic anemia, right? And this Coombs positive hemolytic anemia, especially it is seen in individuals with AB blood group type. Right, AB blood group type. So in these individuals, there is chance of development of Coombs positive hemolytic anemia. And another important complication is anaphylactic reactions to immunoglobulin. Right, there is development of anaphylactic reactions to immunoglobulin. Right, so these are the complications that are associated with intravenous immunoglobulin administration. Now, apart from IVIG, the other important drug in the treatment of Kawasaki is the supplementation of the aspirin. So, although your aspirin does not lower the frequency of development of coronary artery abnormalities, but it has important anti-inflammatory effect and anti-platelet activity. Right, it has important anti-inflammatory effect and anti-platelet activity. Right, so that is about the aspirin supplementation. So, but the point is, this aspirin will not lower, right, will not lower the frequency of coronary artery aneurysm. Right, will not lower the frequency of the coronary artery aneurysm. So you have to give this aspirin, right, you have to give this aspirin along with intravenous immunoglobulin. Right, and how much of aspirin you have to start with? Aspirin, it has to be started at 80 to 100, right, 80 to 100 milligrams per kg per day. Right, 80 to 100 milligrams per kg per day, and this has to be given orally. Right, this has to be given orally, which is divided into 4 doses, but it should not exceed 4 grams per day. Right, so this has to be given in 4 divided doses. Right, but it should not exceed. Right, but it should not exceed 4 grams per day. And you have to give this particular aspirin until the patient is afebrile for 48 hours. Right, until the patient is afebrile for 48 hours. So until then, you need to give this aspirin plus IVIG combination. So once the individual is afebrile, then you need to reduce the dose of aspirin. Right, you need to reduce the dose of aspirin to 3 to 5 milligrams per kg daily. Right, so this should be the dosage once the individual becomes afebrile, or until the markers of acute inflammation have normalized, you should give the aspirin at a dosage of 3 to 5 milligrams per kg per day. right? So this is about the story of aspirin. So aspirin, it has anti-inflammatory and antiplatelet activity, but remember, it will not lower the frequency of coronary artery aneurysm. Then about the corticosteroids. So the use of corticosteroids for children with Kawasaki, it is like controversial. Right, it is like controversial. According to 2017 published guidelines by American Heart Association, single dose pulse methylprednisolone should not be used routinely for patients with Kawasaki disease. Right, so according to 2017 American Heart Association guidelines, single dose methylprednisolone, right, it should not be given. Right, single dose methylprednisolone should not be used routinely for patients with the Kawasaki disease. Next, then in which group of individuals we give corticosteroids? So a course of corticosteroid therapy with tapering over 2 to 3 weeks could be considered in addition to intravenous immunoglobulin and aspirin for patients at high risk for not responding to IVIG. So those individuals who have no response to intravenous immunoglobulin, for them you need to give this corticosteroids. And these corticosteroids, right, these corticosteroids, they have to be given with a tapering dose over 2 to 3 weeks. Right, over 2 to 3 weeks. So that is about the supplementation of steroids. In which group of individuals you have to give steroids? Those individuals who are not responding to your IVIG. Then, if you observe the treatment in resistant cases of Kawasaki disease. See, resistant Kawasaki disease, what is the definition first of all? It is defined as, right, it is defined as having recrudescent or persistent fever. Right, there should be persistent fever for at least 36 hours. Right, for at least 36 hours after the end of first IVIG infusion. Right, after the end of first IVIG infusion, that we call it as persistent fever. So what do you understand by the word persistent fever? Persistent fever means there should be at least 36 hours of fever after the end of first IVIG infusion. That is what is called as the resistant Kawasaki. So this resistant Kawasaki, it is seen in almost 10 to 20% of patients. Right, and for this we have a score called IGAMI score. Right, we have a score called IGAMI score. This IGAMI score, it is a predictor used in Japan to help determine who will respond to IVIG. So it is a predictor that is used in Japan. Right, with the help of this particular score, you will be able to determine who will respond to IVIG. Okay, so that is what is called as the IGAMI score. Right. Now, how do you treat this particular resistant Kawasaki disease? Right. What are the options that we have for the refractory cases? Right, we have multiple alternative drugs for the refractive cases. One option is that you can give second dose of, right, you can give second dose of intravenous immunoglobulin, right, and the other options like what we have is high dose pulse corticosteroids over 3 days with or without a subsequent oral tapering course, right? So you need to give high dose pulse corticosteroids. Right, you need to give high dose pulse steroids that have to be given for nearly around, right, that has to be given for nearly around 3 days with or without a subsequent oral taper course. That is another option for this refractory cases. And the other alternative drugs we have is TNF alpha blockers. And this TNF alpha blockers, examples what we have is infliximab. Right, the example what we have is infliximab. Okay, next, fourth important option what we have an inflammatory marker, that is interleukin 1. So interleukin 1, right, interleukin 1 receptor antagonist, and that interleukin 1 receptor antagonist, the example what we have is anakinra. Right, it is anakinra. And the other options are low dose methotrexate and cyclosporin. So these are the other options for refractory cases who don't respond to your intravenous immunoglobulin and as well as aspirin. Then we have another option of the plasma exchange. So plasma exchange should be considered only in highly refractory cases in which other therapies have failed. Right, highly refractory cases where other therapies have failed, for them you need to do the plasma exchange. Then supplementation of the anticoagulants. One of the most common or the most serious complication in acute phase is the thrombotic occlusion, right? It is thrombotic occlusion of the coronary artery. Right, thrombotic occlusion of the coronary artery aneurysm. Right, coronary artery aneurysm. And because of thrombotic occlusion of the coronary artery aneurysm, that will make the individual to develop myocardial infarction or the development of sudden cardiac death. So an echocardiogram is recommended within 1 to 2 weeks and 4 to 6 weeks after the treatment of uncomplicated patients. So in uncomplicated patients, once you have treated, right, so in uncomplicated patients, what you have to do is you have to do a 2-dimensional echocardiography. And this 2-dimensional echocardiography has to be done within within 1 to 2 weeks and within 4 to 6 weeks after the treatment of uncomplicated patients. Right? Now, what is the anticoagulant that you will give in order to prevent the development of this thrombotic occlusion? Right? You need to give the warfarin. Right? You need to give warfarin. So, anticoagulation with warfarin or low molecular weight heparin, right, or low molecular weight heparin is indicated, but this has to be given along with aspirin, right, this has to be given along with aspirin. So this has to be given in patients with rapidly expanding coronary artery aneurysms. Right, in patients with rapidly expanding coronary artery aneurysms, we give this anticoagulation, warfarin or low molecular weight heparin, that has to be given along with aspirin. Right. So this particular aspirin, which is an antiplatelet agent, anticoagulation, that is warfarin or low molecular weight heparin. The other anticoagulants that can be given is direct acting oral anticoagulants. This direct acting anticoagulants, right, this direct acting anticoagulants, this requires further study in this population. And what are the examples of this direct acting anticoagulants? Like dabigatran, rivaroxaban, apixaban, endoxaban. This requires further study in this group of population. Now, when will you consider to give this anticoagulation along with aspirin? So if the size of the aneurysm, if it is like a giant aneurysm, right, if it is like a giant aneurysm where the size of the aneurysm is like 8 millimeter, in them you need to give this warfarin or low molecular weight heparin. Along with that, you need to give the aspirin. Okay, right. And the platelets from the Kawasaki patients treated with antiplatelet agents do show decreased platelet aggregation function. So whenever you have given this aspirin, that will decrease the platelet aggregatory function. So that is about your anticoagulation in patients with the Kawasaki disease. For suppose, because of the thrombotic occlusion, if myocardial infarction has occurred, then what is that you will do? So if myocardial infarction has occurred, you need to give thrombolytic agents. And this particular thrombolytics, it includes the streptokinase, right? Or the other option that you have is percutaneous coronary intervention, right? You need to do percutaneous coronary intervention, or you have to do coronary artery bypass graft, or even cardiac transplantation should be considered. Right, or even the cardiac transplantation should be considered. So this is about when the myocardial infarction develops in these patients with the Kawasaki disease. Then see, manifestations of coronary artery aneurysms can occur at late as in third or fourth decade of life, with a study showing the prevalence of 5% coronary sequelae from Kawasaki disease among young adults evaluated with the angiography. So when you evaluate these patients with Kawasaki with angiography, that will tell you the chance of development of the coronary artery aneurysm. And remember, this coronary artery aneurysm can occur as late as in third or fourth decade of life, right? So that is about the cover. And even your CT scan, right, that will also show you the presence of calcified coronary aneurysms, right? But these calcified coronary aneurysms on CT scan are less likely to regress, right? They don't regress. So that is about the treatment of Kawasaki. So drug of choice will be intravenous immunoglobulin, right? And along with that, you can add aspirin. But the role of corticosteroids, it is controversial, right? But in which group of individuals we give corticosteroids? In those individuals who are not responding to your IVIG, then we give the steroids. And you should know what do you mean by the word resistant Kawasaki. Resistant Kawasaki means where the individual is having the presence of the fever at least 36 hours after the end of first IVIG infusion. And for that you need to use the IGAMI score. IGAMI score is the predictor used in Japan to help to determine who will respond to IVIG, right? And what are the options for refractory cases? Second dose of IVIG, high dose pulse corticosteroids for nearly around 3 days with or without subsequent oral tapering. Then the other options like what we have is TNF alpha blockers such as infliximab and anti-inflammatory interleukin-1 receptor antagonist, that is anakinra, low dose methotrexate and cyclosporin. And plasma exchange should be considered only in highly refractory cases in which the other therapies have failed. Anticoagulants like warfarin or the low molecular weight heparin should be given in those individuals with the coronary artery aneurysms, and the size of the aneurysm should be nearly around 8 millimeters. And if the individual has developed myocardial infarction, then you need to give the thrombolytic agents, or you have to do PCI or coronary artery bypass graft, and even cardiac transplantation should be considered, right? And calcified coronary aneurysms on CT scan are less likely to regress. Then how is the prognosis in these individuals with Kawasaki? The reported recurrence rate is 3%. Right, the chance of recurrence in Kawasaki is around 3% in one study from Japan. And the highest risk of recurrence, it occurs in the first 2 years after the first episode. Right, the highest recurrence rate it occurs in the first 2 years after the first episode. Okay, so this is about the recurrence. And if you take the mortality, it peaks between 15 and 45 days. Right, mortality, it peaks between 15 and 45 days after the onset of fever. Right, after the onset of fever, the mortality peaks between 15 and 45 days, right? And at the time of coronary artery vasculitis, at this point of 15 to 45 days after the onset of fever, there is development of coronary artery vasculitis, and there will be hypercoagulable state, and that is the reason why the mortality is very high, right? And over the long term, the risk for clinical cardiac events in patients with no coronary artery abnormalities is similar to the general population, right? So that is about your prognosis in these patients. And follow-up is especially needed among the subset of patients with neutropenia, right? In those individuals who have been treated with IVIG with neutropenia, follow-up is very much needed, right? And the administration of IVIG is shown to improve the left ventricular function as well. Okay, so that is about the prognosis in these patients with the Kawasaki disease. Now, when is that you have to refer the patient to the higher center or to get admitted? All cases of Kawasaki merit referral to the specialist definitely. Suspected cases of MISC in patients younger than 21 years should be reported to local or the state health departments. Next, so which one of the following is the treatment of choice for Kawasaki? That is IVIG. Then, now this is how the tongue will be in the Kawasaki, right? So what is this? It is a strawberry tongue. Please remember that. Right, so this is actually an animated image, but this is just to impress you upon how the strawberry tongue appears. Okay, now see, there is one of the very important differential diagnosis for the strawberry tongue, right? The very important differential diagnosis for strawberry tongue is the scarlet fever. Now, in scarlet fever, you have red strawberry tongue, and in Kawasaki, you have white strawberry tongue. And if you see this scarlet fever, it is seen with individuals infected by streptococcus. Right, it is seen in individuals infected by streptococcus, and these individuals, they have fever, right, for nearly around 4 days, and there will be bilateral cervical lymphadenopathy, right, bilateral cervical lymphadenopathy. And in these patients with Kawasaki, you have the presence of the strawberry tongue, and that will be the red strawberry tongue, right, and they also have a rash, right, they also have a rash. That rash, it is of sandpaper in consistency, right, that particular rash, it is of sandpaper in consistency. And what is the treatment for this particular Kawasaki? The treatment for Kawasaki is ampicillin or amoxicillin should be given. Right, ampicillin or amoxicillin should be given. Now, in medicine, we have many strawberries, right? One of the very important strawberry is the strawberry tongue, and differential diagnosis is scarlet fever, and in scarlet fever you have red strawberry tongue, whereas in Kawasaki it is white strawberry tongue. But what are all the conditions where you have strawberry, right? So you have the strawberry nose, then you have the strawberry cervix, strawberry gingiva, and strawberry gallbladder. Let me explain you what are all the conditions where you have strawberry nose. It is present in rhinosporidiosis. Strawberry gingiva, it is present in Wegener's granulomatosis. Then strawberry cervix, it is seen in trichomoniasis. Strawberry gallbladder, it is seen in cholesterolosis. So this is about your strawberries, like what you have in medicine. Now, I said you about the intravenous immunoglobulin. That is a drug of choice in case of Kawasaki. But let me tell you, intravenous immunoglobulin is used in multiple other clinical scenarios. What are those conditions? IVIG is used in myasthenia gravis, idiopathic thrombocytopenic purpura, Takayasu, hemolytic uremic syndrome, multiple myeloma. Now, let me just give you the list of conditions where we use this IVIG. See, IVIG basically what they do is, they will prevent the immune complex formation, or they will prevent the antibodies action for the development of the disease. Okay, so IVIG, it is administered in ITP, that is idiopathic thrombocytopenic purpura, right, administered in patients with the Kawasaki disease, administered in selected patients with graft versus host disease, right, administered in patients with multiple sclerosis, right, administered in patients with myasthenia gravis, then in patients with the Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, and then pediatric HIV infection. Right, pediatric HIV infection. So these are all the conditions where the intravenous immunoglobulin is being administered. So if you see this question now, IVIG is used in myasthenia gravis and as well as idiopathic thrombocytopenic purpura, right? So this is about in total related to your Kawasaki disease. So let me just summarize. It's a type of medium vessel vasculitis. It is also called mucocutaneous lymph node syndrome. So you have the features of vasculitis and you also have the features of the mucocutaneous lymph node syndrome. Vasculitis, most commonly coronary artery is affected. Mucocutaneous lymph node syndrome, that is unilateral cervical lymph node of size more than 1.5 centimeters will be there in patients with the Kawasaki disease. And the criteria is that most common symptom, fever should be there for nearly more than 5 days. Then followed by that, there should be conjunctivitis, right? That too, a non-purulent conjunctivitis or non-exudative conjunctivitis. Then rash, polymorphous rash, which is distributed all over the body, right? Then adenopathy, that is cervical lymphadenopathy. Then the other important thing is mucosal involvement should be there. Okay, so these are the criteria for the diagnosis of the Kawasaki disease. And the investigations, if you see, there will be leukocytosis, raised ESR, CRP elevated, and two-dimensional echocardiography will help you to tell is there any involvement of coronary artery, or you need to do CT angiography. The drug of choice will be intravenous immunoglobulin, and you can add aspirin as well. And if the individual is refractory, we give steroids, or we give second dose of intravenous immunoglobulin, and we have the TNF alpha inhibitors and as well as the interleukin inhibitors, right, as an alternative drugs. So this completes the discussion of this very important topic, Kawasaki disease. Thank you very much.